Hi everyone, my name's Johnson and today I'll be giving a revision lecture on age psychiatry. Before I start, I'd just like to acknowledge all the previous revision lectures and all the PsySOM resources, as they were of great help to me when I was putting together this lecture and also when I was going through fourth year. I also just want to apologize as I had some issues with my audio, so you might have to fiddle around with the volume during this lecture. Hopefully that won't cause too much trouble. In this lecture, I'll be going through neurocognitive disorders, so I'll be covering all the different types of dementia. I'll be briefly touching on some common age-related disorders, including depression and late-onset schizophrenia, and also going through delirium as well, which is quite an important topic. So I'll start off by talking about neurocognitive disorders. So what actually is a neurocognitive disorder? This is a big umbrella term that encompasses any acquired disorder of cognitive functioning. And to be considered a neurocognitive disorder, there have to be deficits in at least one of the 6 neurocognitive domains. Now, typically, what most people think of when thinking about dementia is memory and learning. However, there are also other neurocognitive domains, which include social cognition, complex attention, perceptual and motor, language, and executive functioning. This mnemonic sample here is a good way to remember the neurocognitive domains if you need to recall them, but I don't think it's super necessary for exams. So neurocognitive disorders encompass delirium and dementia, so both major and mild neurocognitive disorders. So we've got the DSM criteria for major and mild neurocognitive disorders on this slide. And I won't go over all of it, but I'll touch on the important points. So to be considered a major or mild neurocognitive disorder, there has to be a decline in at least one of the cognitive domains, and this is evidenced through either concerns from the patient, collateral history of the clinician, and also there has to be a significant impairment in cognitive testing. The main difference between the two is that a major neurocognitive disorder interferes with someone's functional independence, while a mild neurocognitive disorder doesn't. And this is a question that comes up quite frequently in the EMQs, where they'll ask you the difference between a major and mild neurocognitive disorder. So that's the main thing to be aware of. So this slide has a table from one of the previous revision lectures, and I think it's quite a good table which highlights some examples of behavior which highlight the differences between major and mild neurocognitive disorders. So, for example, in the cognitive domain of social cognition, with a mild neurocognitive disorder, there might just be subtle changes in behavior which don't really interfere with independence or ADLs, but in a major neurocognitive disorder, there might be much more severe behavior such as apathy or disinhibition, which would interfere with someone's independence. Another example in memory and learning, someone might have difficulty in recalling events, which is quite mild, might not really interfere with their life, and also can be a part of normal aging. But then if someone's repeating themselves in conversations, that really does quite impair their independence, and that would be why that's a sign of a major neurocognitive disorder. So there are a number of cognitive screening tests which can be used to measure someone's level of cognitive impairment. They can also be used compared to old tests to track someone's progress over time. The main ones that you'll encounter are the MMSE and the MOCA. And you can see at the table on the right that they both test for a number of cognitive domains. You can see that they also test for different domains compared to each other, but the main thing to know is that the MOCA is more thorough, but it takes longer. But because of that, it's more sensitive for measuring mild cognitive deficits. I've seen some older exam questions that ask you to differentiate between mild, moderate, and severe cognitive impairment, and that's usually based on MMSE scores. So 0 to 9 out of 30 would be severe cognitive impairment, 10 to 17 would be moderate, and 18 to 23 would be mild. For the MOCA, a score of under 25 is considered abnormal. And there's also a test called the Frontal Assessment Battery This can be useful for differentiating Alzheimer's from frontotemporal dementia because it tests frontal lobe and executive functioning. Just to give a brief overview about dementia before talking about all the different types of dementia. It's usually a progressive disease that quite significantly affects the elderly population. So 1 in 10 people over 65 have dementia, and 3 in 10 people over 85 have dementia. It was also the second leading cause of death in 2017. The most common type of dementia is Alzheimer's dementia. In terms of features, dementia can affect any of the 6 neurocognitive domains. And different types of dementias can generally affect different domains, although there is quite a lot of overlap between them as well. And around 90% of people with dementia also have BPSD, or behavioral and psychological symptoms of dementia. And these can include apathy, delusions, hallucinations, aggression or agitation, hyperactivity, and can affect affect as well, causing anxiety or comorbid depression. And these BPSD also tend to occur or tend to get worse later in the day, around late afternoon or evening, and that's what we call sundowning. On this slide, I've got a table that's adapted from Vespels, which summarizes 4 main types of dementia. So that's Alzheimer's, vascular, frontotemporal, and Lewy body. And these are the types of dementia that are more likely to come up on your exams. They're just briefly summarizing the course, features, pathology, and also the cardinal features and buzzwords are all bolded. So it's just a brief summary if you want to refer back to this slide. Alzheimer's disease is the most common type of dementia, and the risk factors include increasing age, traumatic brain injury, and there's also a genetic component to Alzheimer's disease, which I'll discuss in the next slide. So the cardinal features of Alzheimer's disease are the gradual onset and progression of disease, and the most prominent early feature is memory impairment. So this can present as things like forgetting recent personal events, losing items around the house, or repetitive questioning. As the disease progresses, it can go on to affect other domains such as executive functioning, language, visuospatial, and cause dysphagia and dyspraxia. And the average survival from symptom onset is around 10 years. In terms of diagnosing Alzheimer's disease, the most accurate way is to do a post-mortem histological diagnosis, and that's looking at the pathology in the brain. However, as you can imagine, that's probably not the best way to diagnose Alzheimer's in most patients. There are also clinical criteria that you can use. In terms of the pathology, Alzheimer's is associated with beta amyloid plaques, which are located between neurons, and these can affect neuron firing, and also neurofibrillary tangles, which are made out of misfolded tau proteins, and these are located inside the neurons. Microscopically, you can see a widening of sulci and narrowing of gyri in the brain. You probably don't need to know too much about the pathology, but beta amyloid plaques and neurofibrillary tangles are quite buzzwordy for Alzheimer's. In terms of making clinical diagnosis, you have to meet the criteria for either a major or minor neurocognitive disease, and then either there's evidence of a genetic mutation associated with Alzheimer's, or there's evidence of decline in memory and learning and one other cognitive domain, and there's evidence that the disease is steadily progressing. So in terms of the genetic mutations associated with Alzheimer's disease, there's the sporadic type, which is associated with more late onset. That's associated with the ApoE4 gene mutation, and this causes problems with breaking down beta amyloid, which leads to the beta amyloid plaques. There's also the familial type, which is more associated with early onset before the age of 65. So there's the presenilin 1 and presenilin 2 gene mutations, which are associated with this type. And also Down syndrome is a risk factor for developing Alzheimer's disease because there's this amyloid precursor protein gene on chromosome 21. which is associated with the development of Alzheimer's disease. And with an extra copy of chromosome 21, there's an increased chance of getting this mutation. Approximately 30% of people with Alzheimer's disease will also experience Alzheimer's disease psychosis at some point during their disease, usually in the later stages. So Alzheimer's disease psychosis is characterized by three main features. That's misidentification. Often they might think that their spouse isn't theirs. There's delusions of theft. This is thought to arise from the short-term memory deficits, and they often forget where they put things and then assume that these items were stolen. And phantom boarder syndrome, when they think that someone else is living at their house. It can also be sometimes difficult to differentiate between Alzheimer's disease psychosis or late onset psychosis or schizophrenia. The management of dementia can be quite challenging, and it often requires a lot of collaboration between within a multidisciplinary team. On this slide, I've summarized the general principles for managing dementia using the biopsychosocial model. It's also important to keep in mind that there may be different management considerations for different types of dementia, especially with medications. With medications, there's no cure, but there are some drugs that can help treat the symptoms of dementia. So the first class is acetylcholinesterase inhibitors, and these include donepezil, rivastigmine, and galantamine. These help to improve symptoms by increasing acetylcholine concentrations. And they're only rarely prescribed by geriatricians or specialized psychiatrists, as there's a risk of dizziness or postural hypertension, which can lead to falls, also bradycardia and incontinence, which are quite significant concerns, especially in elderly populations. Acetylcholinesterase inhibitors aren't used in frontotemporal dementia, as there's no evidence to show that they're effective, and there are also concerns that they could worsen some of the behavioral symptoms in frontotemporal dementia. And they're also not used in dementia due to Parkinson's disease. Second class is NMDA receptor antagonists, and these include memantine. And these work by blocking NMDA receptors, which lead to reduced glutamate transmission. And this can help stop some neurons from dying. So these are used in moderate to severe Alzheimer's disease, and also can be used in combination with any acetylcholinesterase inhibitors. They can also be used in patients who are intolerant of or have contraindications to acetylcholinesterase inhibitors. With regards to the psychological management of people with dementia, it's always important to look out for and support the mental health of carers, as they're very important when managing people with dementia. It's important to promote psychological and social stimulation, so this can be through support groups or encouraging social engagement within the community. And memory stimulation can range from reminiscence therapy to simple things like card games or reading. And a structured activity, structured routines and stable living environments are quite important in people with dementia. It's good to still promote general health with people with dementia, and also for them to have a regular GP to coordinate all the care, which can include a whole range of allied health professionals, including social work, PT, OT, psychologists, dietitians. It's also worthwhile bringing up legal planning as well. So patients with dementia, they can start thinking about advanced care directives while they're still relatively well, or planning for things like residential care, guardianship, or any financial planning. And also other considerations include driving, and also where the patient's going to live, and if they need any assistance at home. Vascular dementia is defined as a progressive loss of brain function due to long-term blood flow to the brain. typically due to a series of cerebrovascular events. It's the second most common cause of dementia, and approximately 30% of people who have had a stroke are diagnosed with dementia within 3 to 6 months. However, it's important to note that not everyone with a stroke will go on to develop vascular dementia. And vascular dementia is not necessarily always due to a stroke. It can be due to other causes that affect blood flow to the brain, such as arteritis. The risk factors to look out for are previous stroke or TIA, and any cardiovascular risk factors such as hypertension, diabetes, smoking, for example. The cardinal feature of vascular dementia is that the progression is usually stepwise. And what that means is that every time there's a vascular event, there's a sudden decline in the patient's function. However, between these vascular events, it usually plateaus or doesn't really worsen. And then so there's plateaus, and then every time there's a new vascular event, there's new symptoms or affects the patient's function. The presentation is variable, as it can often depend on the location of the lesion. To make a diagnosis of vascular dementia, the patient needs to meet the criteria for major or minor neurocognitive disorder, and there needs to be evidence of cerebrovascular disease that's temporarily associated with the onset of cognitive deficits. In terms of management, medications such as acetylcholinesterase inhibitors and memantine aren't really effective in vascular dementia by itself, so they're only used if there's other types of dementia as well. The main treatment is to improve cardiovascular risk factors. That's through lifestyle modification and medication. Frontotemporal dementia is caused by the degeneration of frontal or temporal lobes. And what differentiates this from other types of dementia is that usually the patients present younger, so younger, under 65, which is different from most other types of dementia where the patients are typically older. Now, as it can affect the frontal or temporal lobes, there's different variants. So if it affects the frontal lobe, it can cause change to the person's personality and behavior, and so disinhibition is one of the big buzzwords for frontotemporal dementia. It can also cause language problems such as progressive aphasia if it affects the temporal lobe. And usually there are less memory and learning problems compared to other dementias. There's also a subtype called Pick's disease, which is caused by the tau proteins, which malfunction and accumulate inside neurons, and that leads to the pathology known as Pick's bodies. The DSM criteria for frontotemporal dementia kind of outline the main features. I won't go through all of them, but the patient needs to either meet the criteria for the behavioral variant or the language variant. And in terms of management, it's important to note that acetylcholinesterase inhibitors don't work, as they can sometimes worsen the behavioral symptoms of frontotemporal dementia. So instead, antipsychotics or SSRIs are more typically used. Lewy body dementia is another gradually progressive dementia, and it's characterized by dementia with visual hallucinations and Parkinson features. So it exists on a continuum consisting of Lewy body dementia and Parkinson's disease. In order to be considered Lewy body dementia, the symptoms of dementia have to start before the motor symptoms or within 1 year after the motor symptoms have started. Otherwise, if the motor symptoms start and then after 1 year the symptoms of dementia start, then that's considered Parkinson's disease. So usually patients present with dementia, sometimes visual hallucinations, and then they go on to develop some Parkinsonian features. In terms of the pathophysiology, it's associated with the Lewy bodies. So these are alpha-synuclein cytoplasmic inclusions. So the alpha-synucleins misfolded and they aggregate to form Lewy bodies, often within the substantia nigra, paralimbic, and neocortical areas. But it's also important to note that Lewy bodies are found in other diseases as well, so they're not specific to Lewy body dementia. The hallmark features are visual hallucinations, fluctuating cognition, Parkinsonism, and also people can get REM sleep disorder, and antipsychotic sensitivity. So if you try to treat someone with Lewy body dementia with antipsychotics, that can often result in worsening of their Parkinsonism. I've got the DSM criteria for Lewy body dementia on this slide. I won't go through all of them, but there are core diagnostic features and suggestive diagnostic features. So the core diagnostic features are fluctuating cognition, visual hallucinations, and Parkinsonism, and the suggestive features are REM sleep disorder and severe neuroleptic sensitivity. So to make a diagnosis of probable Lewy body dementia, the patient needs to have at least 2 of these core features, or they need to have 1 suggestive and 1 core. And to make a diagnosis of possible Lewy body dementia, they need to have 1 core feature or at least 1 suggestive feature. In terms of managing Lewy body dementia, acetylcholinesterase inhibitors are the best evidence, and also for the motor symptoms, dopamine analogs can be used. It's important to avoid antipsychotics in Lewy body dementia, as they can worsen Parkinsonism. So those are the 4 main types of dementia, and that leads us to first EMQ. So feel free to pause the video and try to work out the answer for yourself, and I'll discuss the answer in 5 to 10 seconds. So the answer is major neurocognitive disorder due to frontotemporal lobar degeneration, so frontotemporal dementia. We've got a 63-year-old carpenter who's presenting with his wife for relationship counseling. He's denied any particular concerns, but his wife's reported a 2-year history of mood swings, amotivation, road rage, which are completely out of character, and a lack of empathy towards his disabled grandson. His behavior is also placing considerable strain on the family. So first of all, it sounds like it's more of a major neurocognitive disorder compared to a mild neurocognitive disorder, because it's placing considerable strain on the family. It seems like it's affecting him, his life quite a lot. And these behavioral changes, mood swings, amotivation, road rage are quite severe. So in terms of the age, he's on the younger side for dementia. He's 63, so that's already making us think maybe it's frontotemporal. There's all these changes to his personality, which make it quite likely that it is frontotemporal dementia. There's not really any evidence of any memory deficits, which again is in line with frontotemporal dementia, and there's no signs of any hallucinations or motor symptoms, and there's nothing in this question mentions anything about any vascular risk factors or any vascular events. So the most likely cause is frontotemporal dementia. So apart from the 4 main causes of dementia, there are still other causes, other less common causes of dementia. I won't go through all of these in depth, but this table should have most of the important features of each of these types of dementia. So prion disease is caused by prions cause misfolding the protein in the brain, which causes apoptosis, and this is characterized by having very, very rapid progression. And the most common cause of prion disease is Creutzfeldt-Jakob disease. Parkinson's disease, we've already kind of touched on. It's when the motor symptoms of Parkinson's disease occur first, and then after 1 year there's cognitive symptoms. Huntington's disease is another cause of dementia, so this is an autosomal dominant disorder which causes these trinucleotide repeats. The most important features of dementia due to Huntington's disease would be the motor features such as chorea and the early executive function impairment. And HIV can also cause dementia, so it's associated with high CSF viral loads and severe immunosuppression. And it's typically only after long-standing HIV as well. It's important to remember that cognitive impairment can be caused by other things apart from dementia. So I've got a list of some of the more common differentials for cognitive impairment. Normal aging can cause people to forget names, events, or have worse recall. However, these are usually much less severe than the memory deficit seen in dementia, and usually people can still be quite independent. Dementia is a very common masquerade for depression is a very common masquerade for dementia. And it can be quite difficult to differentiate the two, especially because both of them have kind of this gradual onset. However, with depression, these patients can also present with more of the physical signs of depression, such as weight loss and sleep disturbance. And also, these patients can be more worried about the memory loss themselves compared to in dementia, when patients tend to be brought in by the family who are concerned about them and they're not really aware of the cognitive impairments themselves. Normal pressure hydrocephalus is something that comes up quite a lot on EMQs. So it's caused by an accumulation of CSF, which causes the ventricles to dilate, and it causes this triad of incontinence, confusion, and ataxia. So it's just good to keep this triad in mind when you're doing your EMQs, as this has popped up a few times before. Strokes can cause cognitive impairment, but they're usually more sudden onset compared to gradual onset of dementias. And late onset schizophrenia can be a differential. It can be it can be a differential for things like Alzheimer's, like with this Alzheimer's psychosis, and for Lewy body dementia, where you can get hallucinations. So for late onset schizophrenia, people are more likely to have these hallucinations and less likely to have cognitive symptoms. So I've got another EMQ now. Feel free to pause the video to try and answer this question. So the answer is normal pressure hydrocephalus. So we've got a 72-year-old former school teacher with a 4-month history of unsteadiness when walking, loss of bladder control, and difficulty following conversation. On examination, she's got a perplexed affect, slightly anxious mood, and MMSE is 26 out of 30 with short-term recall 1 out of 3. So she's actually got the triad of incontinence, confusion, so it's difficulty following conversations, and perplexed affect, and ataxia, the unsteadiness when walking. So that's those are the signs of normal pressure hydrocephalus. So moving on to the next part of the talk, I'll just be going into a little bit more detail about common age-related conditions, so that's depression and late onset schizophrenia. So you will probably know quite a lot about depression already. I'll just be covering some of the considerations of in elderly populations. So depressions are quite common in elderly populations. So approximately 30% in older hospitalized patients and 40% in older patients with comorbidities, and it's underdiagnosed. It's also significant because it's associated with an increased risk of developing dementia. So It's often more difficult to diagnose older patients with depression. It can be difficult to differentiate it from dementia, and also a lot of the symptoms, such as fatigue, loss of appetite, sleep problems, can be they can overlap with symptoms from some of the patient's comorbidities, or they can be side effects of medications. So it can be hard to recognize those as symptoms of depression. There are some screening tools that can be used, like the geriatric depression scale, for example. So in terms of management of depression in elderly populations, the treatments are quite similar. You want to offer lifestyle and social support, psychotherapy, ECT, and antidepressants. Just with antidepressants, they might take a bit longer to show full efficacy compared to in younger populations. And also the SSRIs, there are higher risks of constipation, falls, delirium, and hyponatremia. So it's important to consider those when treating elderly patients with SSRIs. So the slide has a table that's been adapted from a lot of the previous revision lectures. It's highlighting the differences between dementia and depression, just because it can be quite difficult to differentiate between the two, as they can present quite similarly. I just want to touch on some parts. So with depression, you can get psychomotor retardation and depressed mood and flat affect. And the patients themselves may be worried about the memory loss compared to dementia, where more often the patient's unaware and broadened by family. And also with regard to cognitive testing, the patient might be reluctant or unmotivated to undergo testing such as with the MMSE, and this can reflect in a low score in cognitive testing, which doesn't necessarily reflect their actual cognitive abilities. I've got an EMQ here, so feel free to pause the video and try to answer it yourself. Cool. So the answer is major depression. I've got a 70-year-old male. He's got a 9-month history of almost complete social withdrawal, not attending significant family events that he's previously enjoyed. This is associated with weight loss, previously been highly independent, managing a thrift shop part-time. Bloods are normal, bloods in an exam are normal. And MMSE is 14 out of 30 with short-term recall 2 out of 3 with no points scored after recall tested. So most of this seems quite consistent with major depression. So you've got the social withdrawal, not attending family events that you previously enjoyed, and there's also some physical signs like weight loss. So I just wanted to include this EMQ because this MMSE of 14 out of 30 is it's quite low, and it might make you think, oh, there's a lot of there's some significant cognitive deficits here with this patient, but it mentions that there are no points scored after recall tested. So more likely this patient was probably reluctant or unmotivated to actually complete the testing, and that would be more of a sign of depression rather than any neurocognitive disorders. Late onset schizophrenia is also another condition on the matrix. I'll just briefly touch on some of the important points. In terms of definitions, late onset schizophrenia is defined as the onset between 40 and 60 years of age, and very late onset schizophrenia is defined as onset after 60 years of age. The risk factors are largely the same as schizophrenia in younger patients. However, late onset schizophrenia is more common in females, and also social isolation or cognitive visual hearing issues are also risk factors. When treating older patients with late onset schizophrenia, lower doses of antipsychotics are often needed to treat the symptoms. And also older people are more susceptible to the side effects of antipsychotics. So those are just some management considerations for treating late onset schizophrenia. And lastly, I'll also be covering delirium as part of this lecture. Delirium is a very, very common problem, especially in the aged population in hospital settings. So it affects 25% of patients aged over 65 who are admitted to hospital. It's defined as acute onset fluctuating disturbance in attention and awareness. So it affects someone's ability to focus and also their orientation. And also it can cause disturbances in their cognition. But it's quite acute. It develops over hours or days and isn't the result of any long-standing neurocognitive disorder. And it can also fluctuate quite rapidly over the day. So there are different subtypes of how delirium can present. There's a hyperactive subtype, which can cause hallucinations, agitation, restlessness. And there's a hypoactive subtype as well, which is much harder to recognize because the patients can be withdrawn or fluctuating in and out of consciousness. And there's also a mixed subtype of delirium as well. The risk factors of delirium, things like age, over 65, any pre-existing brain disease, previous delirium, any chronic diseases or comorbidities, functional impairment and polypharmacy can all predispose people to develop delirium easier, but they still need that insult that kind of tips them over into delirium, and I'll be going over those in the next slide. There's lots of different causes of delirium, and often delirium can be multifactorial with lots of different contributing factors. I've got 3 different ways to remember some of the causes of delirium on this slide. There's the 5 Ps, there's dim top, and there's pinch me. I quite like the 5 Ps. I think that one's quite simple. So there's P for UTIs, which are a major cause of delirium. There's POO for constipation, plus for any kind of infection. Pain, just uncontrolled pain can cause delirium, and pills, including polypharmacy and any recent medication changes. There's also, however, this doesn't encompass other causes that are covered with dim top and pinch me. So there's metabolic or endocrine causes, such as any electrolyte abnormalities or hypoglycemia. There's also the environment. So being in a hospital is a major, can be a big cause of delirium as well, because there's a big change in environment, and there's also often a lot of noise. It's an unfamiliar environment as well. In terms of managing delirium, it's quite important to try to prevent delirium from occurring in the first place. And this is because patients who develop delirium have much higher morbidity and mortality. So this can be done by assessing if the patient has any risk factors of delirium, and then implementing preventative strategies. So having a room with sunlight, or having orientation cues such as clocks or calendars, and also being proactive with reviewing the patient's meds and keeping on top of their pain and managing any hydration problems or any constipation. It's important to know how to recognize and diagnose delirium, and that's with the CAM, and I'll go over that a bit more in the next slide. And then the next stage is to investigate for and treat the cause of delirium. So a collateral history is quite useful. It can give insight into the onset of the symptoms, and also give an idea of what the patient is like at baseline. And a good thorough examination and vital signs are important. It can be helpful to review the med chart to see if there are any meds that are necessary, or if there are any there have been any recent changes in any of the patient's medications. And then from this list of investigations, you can try to target your investigations to try and determine the cause. terms of managing delirium, so you have to treat the cause of it. So, for example, treat if it's a UTI, then you want to treat the UTI and also and then also utilize some of these strategies as well. So I mentioned medication review, keeping on top of pain, hydration, and constipation as well. Because patients with delirium can often be quite confused, it's good to implement fall prevention strategies, and then also orientation cues and ensuring that the environment has appropriate lighting and is quiet can help the patient as well. It's also good to inform the family and educate them, as it can be quite distressing if a family comes to visit a patient with delirium. And optimizing sensory perception as well, so making sure the patient can access glasses or hearing aids or anything else that they need. Pharmacological de-escalation isn't, it's not used unless it's absolutely necessary in delirium. So the CAM, or the Confusion Assessment Method, is a tool that's used to diagnose delirium. So for the diagnosis of delirium with the CAM, the patient needs to, there needs to be both acute onset and a fluctuating course. There needs to be inattention, and there needs to be either disorganized thinking or an altered level of consciousness. So this all links back into the definition of delirium. So the CAM has high sensitivity and specificity for diagnosis of delirium in a hospital setting. Lastly, this slide just has a table summarizing the differences between dementia and delirium, and this has been adapted from the previous revision lectures and PsySOM resources. The main differences are that delirium is more of an acute onset and acute fluctuation compared to the gradual onset and gradual decline in dementia. And attention and level of consciousness are often impaired in delirium, while in dementia they're generally intact until late in the course. That brings me to the end of this revision lecture on age psychiatry. If you have any questions, feel free to contact me by email, which is on the first slide. Well, thanks for watching, and best of luck for the rest of the year and for your exams.